There we go. Okay, so as an athletic trainer early on, if you have a shoulder injury or a knee issue, your special tests, your rehab approach is all predicated to the injured area. And as someone who is a muscular system person, we're looking at the whole system. That's what we're responsible for. So yes, it's good to look at those areas, but it's also great to consider the whole body as a system or a machine, if you will, because those little parts can sort of dictate or kind of give you clues as to why something has failed in the first place, if that makes sense.
Yeah. Why do you think, such a focus on, I injured my knee, I strained my ACL, or
Sure.
I have a meniscus, bruise, or whatever they might think. And then the focus becomes on, exercises just for the knee, right? For the most part, knee extensions, knee flexion, balancing on the injured leg, whatever. I mean, why do you think that is? Is that a body view, body philosophy issue? Is that, insurance and time constraints? Just say, look, I don't have time for all this other stuff, so we're just going to focus on the knee.
Yeah, I think it's all those combined. I think part of it too is, people always come to us because they have sensation problems. They're like, get rid of this sensation. I don't like it. And we're just, as a culture, I think, just so glued to that body part. So, okay, you have a knee problem. We don't know any different or better to say, let's look at something unrelated. So therefore, we're going to base our exercises again on the injured area. So if it is a knee, we're looking at hamstrings, calves, quads, maybe shin stuff, if we're even thinking outside that box. So I don't really think we're, again, looking at other parts to consider, because that's, at least for me, that's what I'm finding more oftentimes than not.
Yeah, that's an interesting thing, right? Because clearly, the academic process is very intense and rigorous, for athletic trainers, and they know the body's interconnected, and the knee, is connected to the hip and to the ankle and the foot, and that the hip's connected to the spine through the pelvis, right? And again, what do you think's missing that they wouldn't even consider? Wait, I better look at the lumbar spine, or the hip area and the upper thoracic area as part of restoring the knee injury or sensation in the knee problem.
Yeah.
What do you think's missing from that thought process?
I think the most simplistic way to answer the question is simply one word: system. So you look at the charts and they say muscular system, neurological system, skeletal system. I think we forget that fact, and we look at other things like software or some sort of engineering piece. There's all these integrated parts that make up the whole system, and we have to look at all those things if we're talking about that specific device. But when we view the human body, for whatever reason, again, it's just, we're tunnel vision. We're looking at one thing.
Yeah, so that's,
to me, that's the biggest thing.
Because as well, diagnostically, right? There are names given to these things, right? You have your left lateral knee ligament, right? Lateral collateral ligament is sprained. Okay, so then there's the material side, which I can understand that, right? It's like, okay, that material has been degraded in some way, and so we need to figure out how to restore that material, give it some stimulus to rebuild itself, right? And that kind of makes sense, kind of encourage the immune response, and drive that a little bit. So I think that makes sense. But a concept like the joint receptors and the ligament receptors, and the fact that afferently they impinge on the spinal cord and have diverse projections throughout the spinal cord, that can potentially change motor pool firing or recruitment frequencies elsewhere in the system. That concept is taught, right? But it's not really carried out like, oh, wait, the knee joint and the ligament and all these tissues have all these sensory receptors that go up into the spinal cord that attach and reach out and touch all kinds of other things that could affect the hip, the spine, the opposite shoulder, right, the foot and ankle. is that not discussed traditionally in the academic process or in the clinical settings?
If I had to guess, because it's been over 10 years now, I would probably say yes. But the difference is there's really no course of action really to consider. So maybe that thought process is again laid out, but what do you do with that sort of thing? And it's kind of, there's really no explanation for it until, we start learning what you've taught me and what others have taught me to kind of think outside that box a little bit.
Yeah, because I think that's an important thing. Like, so even if you suspected maybe it's affecting the lumbar spine, how would you check? How would you even assess a relationship between the left knee and a lateral collateral ligament injury, and whether the lumbar spine is involved in that, right?
Yeah, because I think if you start doing that, then without any dialogue with who you're working with, I think it's just, you start doing that sort of thing, and then they're going to ask you the notorious question. Well, it's my knee that's bugging me. Why are you looking at my trunk? Like, doesn't make any sense. If there's no explanation for that, because again, it hasn't been taught that way. Maybe it's been addressed, but not taught. That's where you run into some issues. But now we have a good rationale or reason to describe that to somebody. It makes more sense.
Right. Through the muscle system specialist.
Exactly.
Philosophy and methodology. Expand the reasoning. It is amazing to me, even still after practicing, this long and thinking this way and using these ideas, that someone who's still complaining about a knee problem that's associated with a known injury to a lateral collateral ligament, and we explore the way we do with the QMAMC and the SARS and isomyoplyls, the lumbar and contralateral shoulder areas, and find motor quality output issues there. The way we do that, restore them, and now the knee pain's gone, and we didn't even touch the knee.
Yeah, and I love the reaction. Always like, "What the heck is this?" Like, well, that's where we're having the issue. Your body's telling me that. I'm not telling you that. Your body is.
Right. And so you think, so that could be again one of the that old paradigm of nociceptors are. They're the sensory receptors that when they depolarize locally, that's what causes pain, not the emerging idea and what we use in information set theory, to say, well, no, the whole system and its information flow and governance is being concluded and edited and revised by the central system, and based on the total system information, it's still concluding pain over here. And then we alter that information flow and improve it, and the brain says, oh, I don't have to worry about concluding pain now. Even if there still could be lateral collateral ligament cellular damage, right, an inflammatory process going on. Just because there's no pain doesn't mean that isn't going on, and that tissue still doesn't need to be attended to.
Right.
But as far as the sensation side, that is a remarkable thing. And again, that would be something that's lacking in traditional clinical education, right, is looking at the rest of the system as an information processing apparatus, and that any information can improve any other part as the information flow is improved. So, wow.
Yeah, it still blows me away. I mean, even to this day, and you have to keep addressing the same thing to these people who haven't experienced this before, and it's like, how do people not know this sort of thing? That's what I always think in the back of my head, because it seems so elementary to you and I, and it's not, as a society, and that's crazy.
Yeah, because it's in the literature. It's not like we're just making this up pie in the sky. We see all the clues and all the pieces in the literature. It's just a matter of saying, oh, we got to put all this together, and we realize, oh, this is the story. This is the kind of reverse engineering the problem, right? Like, oh, wait a second. This attached to that. This communicates with that, and that, excitation and inhibition. This, right? Hold on a second, right? My left lower extremity is related to my right upper extremity through the central pattern generator system, right? Which is in the, it's like, oh yeah, okay. that could be why, right?
Absolutely. I
Hmm.
mean, it's like I say, it's crazy to me to think that people don't get that sort of thing, but
Right, right.
it is what
Well,
it
we'll keep talking about it and trying to get them over to www.exerciseproed.com. Shameless
is. Right.
plug, right?
That's
And,
right.
and teach them the muscle system specialist thinking model, right? The body view, and then these methodologies that do that. Yeah, I just had a client. I got started referred by a doc.
Hmm.
She just spent a year doing what you describe, right?
Oh
Shoulder,
yeah.
hurt her shoulder in yoga, and everybody's putting shots in the shoulder and rubbing the shoulder and ultrasound on the shoulder and acupuncture on the shoulder, stretching the shoulder, right? And zero change in her shoulder pain. Let
How long
alone
have you seen the therapist?
how long had she seen one?
Yeah.
I think she saw a PT for 6 weeks or so, two,
Okay.
3 times a week, right?
Sure.
So a lot of people taking stabs at it.
Mhm.
And then, yeah, we look at this approach, and I saw some issues with her lumbar spine, right, and thoracic area, and we got that shored up, and her shoulder's feeling better. And we haven't done anything yet directly to the shoulder.
Yeah, crazy.
It's just a bizarre.
And I can
Again,
only
not that the shoulder might not need some attention, right? It still might, right? Especially considering all the shots stuck in there and all the rubbing and the deep tissue and all
yeah,
these other things that might have caused some trouble.
most definitely. I mean, there's probably some irritation involved with that area. And clearly after 6 weeks, there hasn't been any resolve. So it's,
A year, a year.
yeah, I mean, that's a long, long time to
Long
be under
time.
that sort of stress.
Yeah,
Crazy.
yeah. It's
But
pretty
like you say, you look at other parts and then you make some improvement and she's blown away by that. All right. Yeah, that makes sense.
Yeah, how's that possible? Yeah, we found out she had, when she was a teenager, a palate spreader, right?
Yeah.
That'll change your skull. And
That is the one thing that's interesting is the people that have gone through, historically all these different things and how truthfully that has added up to, what their current state is physically. Um, I mean, I can't stress that enough how important that is. Just to have that, to your advantage, just to have it in front of you and just say, oh, you've had this when you're a teenager. Okay, that's interesting. Maybe that's
yeah,
where
she dislocated her left meniscus and her TMJ. Right?
okay.
Yeah, right. So
That's crazy.
yeah, and we checked the neck, and there was some low quality output in the neck, and
Sure.
it was affecting her left side or the shoulder. Yeah,
It's wild.
good stuff. Yeah. So clearly, we got to get thinking outside the box.
100%. I mean, I can't stress that enough.
Well, hopefully, modern clinicians, will start to think, wait a minute, there's got to be another way to think about this,
Mhm.
um, and go from there. What advice would you have for, a modern athletic trainer who's kind of myopically stuck in that local symptom must mean local problem, and I can only really institute local solutions?
Yeah, I think. Excuse me a second. I think if it's a newer person, there's a little bit more of a chance, but an experienced athletic trainer, it almost seems like they almost don't want to learn anything new for whatever reason. And of course, it depends on the person. I get that. Uh, but I feel like with someone who is, fresh out of college, and I'm going back to myself, I was fresh out of college. I was given outside the box ideas that exactly what we're talking about. And it sort of changed the path as far as how we go about things or how I would go about things. And when you see that change systematically, sensation wise for the client, it's like, okay, that's really interesting. I never thought about that. And then you have the thought of, no one else is doing this sort of thing. That's really cool because it is unique and it is making headway. Not to disregard what I did learn in college, but it just
Oh,
seems like, right. But what I'm doing now, it just seems to be way more effective. And from a business side of things, it makes you more valuable in a sense because, and you've said this before, we're able to problem solve some pretty complex things given the system that we've been taught. So I think for someone who is just fresh out of college, it makes more sense for them to take on these new ideas, but someone who's been, 10, 20, 30 years in the business, it may be a little bit more difficult unless they are having a situation where they're having troubles working with a case and they can't get over, that person's pain, because that's really what they're there for, to get rid of the pain.
Right.
And if they're not doing that, then yeah, there could be some frustration involved, and maybe they are more open to different ideas, or they just like learning stuff and they want to just learn stuff anyways. They're not just hunkered down to this tunnel vision idea, like you were saying. So
Yeah, I agree. I hope that there's some lifelong learners out there.
and certainly not to disregard what they learn is not
Oh,
bad. They have some validity what they do, and
absolutely.
I just like the idea of having more tools in the toolbox as
Right.
opposed to just one or two. And be more open-minded to things, I think, is the best way to go about it. Because I mean, how else are you supposed to learn some things unless it's just the same path? So again, I think for me that was the biggest thing I caught early on, and I was seeing some interesting things happen, and I was sort of glued to that.
Great.
So
Outstanding. Well, thanks for your time and your input on that subject. I really think it's important, Andrew, especially for you as an athletic trainer in private practice now, which is nice, right?
yeah,
Um,
super nice.
yeah, and letting other athletic trainers know there's some other things they can learn and maybe consider from a career option to be in private practice in their communities, solving complicated musculoskeletal issues and associated pain. So
Yeah, one thing I will stress is because of that, it has allowed me to have my own private practice. Whereas, and I've talked to other athletic trainers, there's not hardly any of them that are in private practice. So to have that for me personally is very special.
yeah,
But to have this to, the access to these people is very beneficial and gives them the opportunity to kind of replicate what I'm doing. And I think it makes them more valuable. And it makes them want to stay in the profession, because there is unfortunately quite a few that do leave the profession because they're not being, or they don't get compensated as much as they'd like, and they're working so many hours.
right.
And that is something that they are told in college, like, you're going to work a bunch of hours, but you're probably not going to get paid unless you do make it to the professional level, which is crazy to think, but that is the reality of it.
Which is like 1% of the 1%.
Yeah. So to be hunkered down by that it's just wild. But I think if you have the opportunity to learn different things and create the value there, that gives you the opportunity to be in a situation like myself. And I'm super thankful for that, like I said.
Yeah, it's
So
fantastic. Fantastic. All right, sir. Well, thank you very much. I really appreciate talking to you, and we'll try to keep this conversation going.
absolutely, my pleasure. Appreciate it.